What if the tiny glands perched on top of your kidneys could decide how your body reacts to stress, burns fat, balances salt, even controls how you feel? Welcome to the world of the adrenal glands, your body's silent regulators. They're small, but powerful. Two triangular glands, one on each kidney, working 24/7 to produce life-sustaining hormones. From the rush of adrenaline in a crisis, to the slow, steady rhythm of cortisol that shapes your sleep, energy, and immunity. But what happens when this system breaks down? From the hidden threat of Addison's disease, to the hormone storms of Cushing's syndrome, to the tumors that can mimic a panic attack. This is not just about glands. This is about the core of your internal balance, and what happens when it spirals out of control. In the hidden recesses above your kidneys lies a small but mighty force, the adrenal gland. Shaped like a pyramid, no bigger than a walnut, yet capable of swinging your body into action, survival, or shutdown. Each adrenal gland is divided into two major regions, the outer cortex, and the inner medulla. Two different zones, two very different missions. Let's begin with the cortex. The adrenal cortex is further divided into three histologically and functionally distinct zones, each producing different classes of steroid hormones. Zona glomerulosa, the outermost layer. This is the zone of salt. Its cells synthesize aldosterone, a mineralocorticoid crucial for sodium retention, potassium excretion, and blood pressure regulation. The synthesis here is regulated mainly by the renin-angiotensin system, not ACTH. Zona fasciculata, the middle and largest zone. This is the zone of sugar. Here, the primary product is cortisol, the body's key glucocorticoid. Cortisol regulates metabolism, stress response, inflammation, and immune modulation. This zone is regulated by ACTH from the anterior pituitary, under circadian and stress control. Zona reticularis, the innermost cortical layer. This is the zone of sex. It produces adrenal androgens, mainly DHEA and DHEAS, weak androgens that serve as precursors to more potent sex steroids. While ACTH stimulates their production, the specific regulatory mechanisms remain partly elusive. Steroidogenesis in all three zones begins with cholesterol, transported into the mitochondria, where the action begins. The process is tightly compartmentalized, and specific enzymes in each zone determine which hormone gets produced. Now, let's step into the adrenal medulla. Unlike the cortex, the adrenal medulla isn't governed by hormones, but by the nervous system itself. The medulla is a specialized extension of the sympathetic nervous system. Instead of sending nerve signals outward, it releases catecholamines directly into the bloodstream, epinephrine and norepinephrine. These are the body's rapid responders. Within seconds, they raise heart rate, boost blood pressure, open airways, and redirect blood flow to muscles and brain. It's the classic fight or flight response. Interestingly, the synthesis of epinephrine in the medulla requires cortisol from the cortex. This creates a fascinating interplay. The inner medulla relies on the outer cortex to fully arm itself. The body is a stage, and cortisol, it plays both lead and director in a performance that touches every cell, every moment of your day. Produced in the zona fasciculata of the adrenal cortex, cortisol is the signature hormone of stress, metabolism, and wakefulness. Its release is no accident. It follows a rhythmic dance directed by the hypothalamic pituitary adrenal axis. The curtains rise in the early morning with cortisol at its peak, setting the tempo for energy, alertness, and glucose regulation. As night falls, its levels recede, unless something's gone wrong. And when that rhythm falters, enter the chaos of Cushing's. Cortisol, master of balance. Cortisol isn't just a stress hormone, it's a regulator of life's essentials. It ensures glucose availability during fasting, tames the immune system, maintains vascular tone, and subtly modulates our mood and memory. But like any conductor, when it plays too loud or too long, the harmony collapses. Cushing's syndrome, a hormonal uprising. When cortisol levels surge uncontrollably, from within or through chronic glucocorticoid therapy, the body pays a price. Think central obesity, moon face, that unmistakable buffalo hump. Skin thins, muscles waste, emotions run high, or numb. Welcome to the world of hypercortisolism. But diagnosing Cushing's isn't a one-test game. Cortisol doesn't sit still, it pulses, fluctuates, and hides behind variables like metabolism, compliance, and even emotional stress. Step 1. Catching the excess. The 24-hour urine-free cortisol, UFC, test is the first gatekeeper. If cortisol floods the bloodstream beyond what carrier proteins can bind, the excess spills into urine, and that's where we look. With tandem mass spectrometry, we can detect these levels with near-perfect accuracy. But here's the twist, nearly half of confirmed Cushing's patients can show a normal UFC result. That's why repetition is essential. Random cortisol, forget it. It's unreliable. Cortisol dances to a daily beat. Step 2, the rhythm that shouldn't be. Normally, cortisol dips at night. In Cushing's, that drop disappears. Midnight salivary cortisol, easy, non-invasive, becomes a powerful window into that disruption. A midnight serum level above 7.5 micrograms per deciliter is a blaring siren. Even more telling, the pairing of midnight salivary and post-dexamethasone levels, a diagnostic duo boasting 100% sensitivity and specificity in some studies. Step 3, the dexamethasone test, a challenge to the system. We challenge the feedback loop. Give dexamethasone, a synthetic glucocorticoid, at night. By morning, cortisol should be quiet. If it's still blaring, we've got trouble. This test isn't foolproof. Depression, alcoholism, obesity, they all cloud the waters. So while a normal result can calm our fears, an abnormal one that needs a deeper dive. Step 4, the ACTH question. Now we ask, who's calling the shots? The pituitary or the adrenal? In ACTH-independent cases, like adrenal tumors, ACTH is suppressed and cortisol runs high. In ACTH-dependent ones, like pituitary adenomas or ectopic ACTH secretion, both are elevated. To localize the source, we head to the veins, the inferior petrosal sinuses. If the ACTH ratio is skewed toward the center, it's pituitary. If not, we're chasing ectopic production. Imaging the enemy. CT and MRI help us see what's lurking in the shadows. Adrenal tumors, pituitary microadenomas, or a distant culprit in the chest. The treatment stage. For adrenal causes, remove the source. For Cushing's disease, pituitary surgery is the frontline act. If that fails, radiation enters the scene. Ectopic ACTH syndromes are trickier. If you can't remove the source, you may have to silence the adrenals altogether. After the storm, bilateral adrenalectomy demands lifelong hormone replacement, and it opens the door to Nelson syndrome, a pituitary tumor's last rebellion. Surveillance never ends. Cushing's may retreat, but it's never truly gone. Beneath the more famous rhythms of cortisol and aldosterone lies a quieter pulse, one that shapes puberty, sexual health, and subtle aspects of metabolism. These are the adrenal androgens, overlooked by some, but essential to many. They're born not of the outer layers, but deep within the zona reticularis. DHEA and its sulfate form, DHEAS, emerge as byproducts of cortisol synthesis. Their production is nudged by ACTH, and perhaps by lesser-known players, prolactin, certain immune peptides, and the whispers of T lymphocyte signaling. But even now, the precise mechanics of androgen regulation in the adrenal R zone remain an enigma. What we do know, these hormones matter. The builders of youth. In childhood, adrenal androgens rise quietly, initiating the first hints of hair growth, body odor, and mood shifts. It's called adrenarche, a silent preview of puberty. By young adulthood, their levels peak, and then, they fade. Slowly, steadily, with age. In men, the adrenal contribution to testosterone is minor, less than 5%. But in women, it's everything. Up to 2/3 of a woman's testosterone comes from adrenal precursors like DHEA. These precursors themselves are weak, but their transformation in peripheral tissues is what counts. In the skin, the hair follicles, the fat, and the prostate, they become androstenedione, testosterone, and even estrogens like estradiol and estrone. When balance breaks, the androgen storm. Too much androgen, and the signs are swift. In girls, ambiguous genitalia. In children, precocious puberty. In women, acne, hirsutism, clitoromegaly, even infertility. In men, paradoxically, excess adrenal androgens can suppress the testicular axis, leading to infertility, feminization, and hypogonadism. Early epiphyseal fusion in children means tall-for-age kids who never reach their genetic height. In women, menstrual irregularities and male pattern baldness may follow. In men, signs of androgen excess can mask a drop in true testicular function. Diagnosing the invisible surge. Because gonads contribute little to DHEAS and DHEA, elevations in these hormones strongly suggest adrenal hyperandrogenism. But testosterone, that's trickier. It could be adrenal or gonadal. That's why we measure multiple markers. Plasma DHEAS and DHEA. Urinary 17-ketosteroids. Androgens downstream like testosterone and androstenedione. Elevations in these, especially in females with signs of virilization, point us toward the adrenal cortex. Finding the culprit. We ask, is this ACTH's doing? We turn to dexamethasone suppression tests. If the excess androgens drop, the cause is ACTH-driven, like a pituitary or ectopic ACTH source. If not, it may be an adrenal tumor, secreting independently. Imaging with CT or MRI helps us find the source. Adenomas are typically small and benign. Carcinomas, larger and aggressive. Treatment: taming the storm. Remove the tumor, if one's found. Address ACTH excess with pituitary surgery or medical therapy. Discontinue exogenous DHEA sources. And for those struggling with symptoms, anti-androgenic medications like spironolactone or birth control pills may ease the effects. Supplemental DHEA is a gray zone. Popular, yes, but poorly understood. Some claim it boosts mood, bone health, and anti-aging effects. But long-term safety, still unclear. In truth, it's not DHEA itself that acts, it's the hormones it becomes. And in the end, the downstream players may carry both benefit and risk. At the heart of the adrenal gland lies its most primal force, the adrenal medulla. No cortex, no hormones of slow transformation, just raw electricity, catecholamines, launched into the bloodstream at the speed of thought. Here, stress doesn't whisper, it roars, a sympathetic spark. The adrenal medulla is no ordinary gland. It's a modified sympathetic ganglion. No axons needed, just direct secretion. When the alarm sounds, hypoglycemia, trauma, fear, chromaffin cells fire. Epinephrine, instant messengers of survival. Cortisol, from the cortex just outside, primes the medulla to convert norepinephrine into epinephrine via phenylethanolamine N-methyltransferase. It's a brilliant design, one zone prepping the next. Synthesis and surge. Catecholamines are born from phenylalanine, transformed step by step into dopamine, then norepinephrine, and finally epinephrine. Dopamine enters vesicles, becomes norepinephrine. In medullary chromaffin cells, some norepinephrine leaks into the cytosol, meets cortisol's influence, and becomes epinephrine. The result? A powerful cocktail stored in vesicles, ready to be unleashed. Clearance. The quiet exit. Catecholamines act fast, but they don't linger. They vanish through three paths. Reuptake into neurons, uptake by liver and other tissues, enzymatic degradation via COMT and MAO. Their breakdown yields metanephrines and vanillomandelic acid, VMA, which are excreted in urine. When the medulla turns tumor, pheochromocytoma. In fewer than 0.1% of hypertensive patients, the adrenal medulla becomes a source of terror. Pheochromocytomas, tumors of the chromaffin cells, flood the system with catecholamines. The result? Surges of hypertension, headaches, palpitations, sweating, panic. Some are misdiagnosed with anxiety disorders. Others go years without a clue. The symptoms are unpredictable. Some have episodic attacks. Others, sustained hypertension. A few present with orthostatic hypotension, cardiomyopathy, or even erythrocytosis. Diagnosis is a biochemical challenge and a clinical detective story. To unmask a pheochromocytoma, that rare, volatile tumor of the adrenal medulla, one must listen to the language of catecholamines. Biochemical breadcrumbs. The gold standard, a 24-hour urine collection measuring fractionated catecholamines and metanephrines. It captures the metabolic echo of a tumor too secretive to catch in a single moment. Sensitivity and specificity soar, each nearing 98%. Plasma metanephrines offer a faster snapshot. A sensitivity of nearly 100% makes them powerful for screening, but their specificity falters, especially in the elderly. The noise of false positives can mislead. Low levels, they nearly rule it out. High levels, they scream pheochromocytoma. Still unsure. Clonidine enters the stage, not to suppress the tumor, but to test its independence. In a healthy body, clonidine hushes sympathetic outflow. In pheochromocytoma, the storm rages on. Plasma catecholamines remain elevated, a clear sign of autonomous secretion. The hunt begins, imaging the beast. Once the biochemistry points the way, imaging reveals the hiding place. CT or MRI of the abdomen, your first tools. Pheochromocytomas shine on T2-weighted MRI, hyper-intense against a muted background. Sensitivity, nearly perfect. Specificity, less so, as incidentalomas muddy the waters. When precision is paramount, MIBG scintigraphy steps in. This radioactive analog of norepinephrine homes in on the tumor with 100% specificity, no false positives. And for metastatic disease, PET scans using fluorodopa or hydroxyephedrine map the terrain with eerie clarity. Preparing for battle, treatment strategy. Every pheochromocytoma is a surgical story waiting to unfold, but the path to the operating room must be paved with preparation. Alpha blockade comes first. It's not optional. These tumors don't forgive a misstep. Without proper blockade, surgery can trigger hypertensive crises. Calcium channel blockers may follow, taming the surges. Beta blockers, only after alpha blockade, never before. To block beta alone is to invite disaster, unopposed alpha constriction. Then, with blood pressure stable, the tumor is removed. Mortality is low, success rates high, when the plan is followed. After the cut, surveillance and surprise. But the story doesn't always end with the scalpel. Even after resection, recurrence looms. Those with familial syndromes, extraadrenal tumors, or right-sided lesions face higher odds. In one series, 16% of patients had recurrence. And among them, over half were malignant. Long-term monitoring isn't a luxury, it's essential. The silent stranger, adrenal incidentaloma. And then, there are the masses you weren't looking for. The adrenal tumors found by accident. The incidentalomas. Most are benign, most are silent, but all must be questioned. Are they secreting cortisol, aldosterone, catecholamines? Are they growing? Are they larger than 4 centimeters? If yes to any, surgery becomes the next chapter. In an age of scanning everything, we must remember, the adrenal gland can whisper before it screams. In the age of scanning everything, we become archaeologists of our own anatomy, discovering mysteries we weren't even searching for. And so, enters the adrenal incidentaloma, a shadow on a CT, a bright spot on an MRI, a silent mass, larger than 1 centimeter, lurking on top of the kidney, found not because of symptoms, but by accident. A hidden prevalence. Autopsy studies tell us a quiet truth. Up to 6% of people harbor adrenal adenomas, most of them unaware. And with age, this number climbs. The older we get, the more secrets the adrenal gland seems to hold. But is it friend or foe? That's the question every clinician must ask. Because although most incidentalomas are benign and non-functioning, a few are wolves in glandular clothing, secreting hormones or hiding malignancy behind their silence. Step 1. Is it functional? We must screen for hormonal hypersecretion, not just to catch disease, but to unmask risk. 3 questions guide us. Is it secreting cortisol? A 1 mg overnight dexamethasone suppression test tells the tale. If cortisol doesn't fall below 1.8 μg/dl the next morning, autonomous secretion is likely. Even if the patient doesn't look Cushingoid, this, subclinical Cushing's, can contribute to diabetes, hypertension, and bone loss. Is it secreting aldosterone? Especially in hypertensive patients with low potassium, screen for primary aldosteronism, using plasma aldosterone concentration and renin activity. Is it secreting catecholamines? Fractionated plasma metanephrines or 24-hour urinary catecholamines help rule out a pheochromocytoma, even if the patient is asymptomatic. Step 2. Is it malignant? Size matters. Less than 4 centimeters. Observe, unless it's functional. Greater than or equal to 4 centimeters. Surgery becomes more likely. The risk of malignancy grows with every centimeter. But size isn't everything. Growth rate and imaging characteristics play crucial roles. Homogeneous, smooth borders, low attenuation, less than 10 HU on CT, likely benign. Irregular, heterogeneous, calcifications, raises red flags. If the lesion grows more than 1 centimeter over 6 to 12 months, or changes character, intervention becomes warranted. The follow-up protocol. Not every incidentaloma is a ticking time bomb, but all require structured follow-up. Repeat imaging at 6 to 12 months. If stable and non-functional, longer intervals are acceptable. If functional, unstable, or enlarging, surgical consultation is necessary. Because while most of these adrenal whispers fade into the background, a few, left unchecked, may one day scream. Small glands. Massive power. From cortisol's quiet control to the explosive surge of epinephrine. The adrenal glands are the unsung gatekeepers of balance. But when they falter, they don't just disrupt hormones. They rewrite the entire script of health. Cushing's, cons, pheochromocytoma. Each tells a different story, but shares a single truth. Early recognition saves lives. So stay curious. Stay sharp. Because the adrenal gland may be silent, but it always speaks. And here, we're always listening. Subscribe. Learn more.